What exactly is macrocytic anemia? Well, it really all boils down to the size and the substance of our red blood cells. Okay, take a look at this. It's a perfect side-by-side comparison. On the left, you've got your healthy, normal, what we call normocytic red blood cell. It's got a typical size, a normal volume, and you can see that little pale spot in the middle? That's its central pallor. But now, look to the right. That is a macrocyte. It's obviously bigger. Its mean corpuscular volume, or MCV, is greater than 98 femtoliters. And notice how that central pallor is gone? This often gives it a slightly oval shape, which is why we sometimes call it a macroovalocyte. This right here is our first big visual clue that something's not right. But here's a crucial point. Not all big red cells have the same story. Macrocytosis actually splits into two major categories. You've got your non-megaloblastic type, which can be caused by things like alcohol or liver disease. But the one we're focusing on today is the other branch, megaloblastic anemia. And this is the key distinction. It's not just about the cell being big. The defining feature here is a very specific problem happening back in the bone marrow, and it's all caused by defective DNA synthesis. And this defect in DNA synthesis leads us to the absolute core of the problem, a really fascinating phenomenon called asynchronous maturation. Think of a cell's development like a clock, where the nucleus and the cytoplasm are supposed to mature together, in sync. But in megaloblastic anemia, it's like the hands of the clock are pointing in totally different directions. Because DNA synthesis has ground to a halt, the nucleus stays big, it stays immature, but at the same time, RNA and protein synthesis are just humming along, no problem. This causes the cytoplasm to grow and mature normally. It's this fundamental mismatch, this asynchrony, that is the true hallmark of megaloblastic change. Okay, so we've got the what down, but now for the why. Why does this happen? Let's start unraveling the etiology, the root causes behind that defective DNA synthesis. As you can see from this map, there are a few potential culprits. The defect in DNA synthesis can be something you're born with, a congenital issue, or it can be caused by certain drugs. But, and this is the important part, far and away the most common causes are nutritional. It almost always comes down to a deficiency in one of two things, vitamin B12 or folate. And those two are going to be our main focus for the rest of this explainer. Now, this slide here is absolutely key to understanding the clinical picture. Let's compare our two vitamins. B12, also known as cobalamin, you can only get from animal products, and it's pretty tough. It holds up well during cooking. Folate, on the other hand, is found in leafy greens, and it's delicate. It's easily destroyed by heat. But check out the body stores. This is the critical difference. We have enough B12 stored up in our bodies to last for 2 to 4 years. In contrast, our folate stores, they'll be gone in just 4 months. This explains so much, like why a folate deficiency can show up so much faster clinically. Okay, let's dive into our first major player. We're going to trace the really complex journey of vitamin B12, all the way from its pretty unique origin right into our cells. You know, the origin story of B12 is actually pretty wild. At its chemical heart, you've got this complex corrin ring with a cobalt atom right in the middle. But here's the twist. In all of nature, it is synthesized only by microorganisms. That's it. Plants can't make it, so animals like cows get it from the microbes in their environment, it builds up in their tissues, and then we humans get it by consuming those animal products. Getting that B12 from our food into our system is like a very specific biological relay race. Once B12 gets into the stomach, it has to bind to a special protein called intrinsic factor, or IF, which is made by the stomach's parietal cells. This new IF-B12 complex then travels all the way down to the very end of the small intestine, an area called the terminal ileum. And there, a specific receptor called cubilin is waiting to grab the complex, pull the B12 inside, and the IF gets broken down. If any single step in this chain breaks down, you're going to end up with a deficiency. Now, this visual really helps explain why just measuring the total amount of B12 in the blood can sometimes be misleading. See, B12 is carried by 2 different proteins in the plasma. Think of haptocorrin as a giant dump truck. It carries most of the B12, like 80% of it, but it's just for storage. It doesn't actually deliver its cargo to the bone marrow where it's needed. It's functionally inert. The real hero of the story is Transcobalamin 2. It's like a speedy motorcycle courier. It carries only a tiny fraction of the total B12, but it's the one making all the essential, high-speed deliveries to the cells that are crying out for it. All right, we've covered B12. Now let's switch gears and talk about its partner, folate. We're going to look at the metabolic cycle it has to go through to get from our diet all the way to our DNA. Folate's journey is all about modification, kind of like building with Legos. In our food, it exists as these long chains, which we call polyglutamates. Now, to get absorbed from our intestine into our blood, those long chains have to be snipped down into single units, or monoglutamates. But then, as soon as it gets inside the target cell, the cell immediately starts rebuilding that chain, turning it back into an active polyglutamate. Why? Well, this process traps the folate inside the cell so it can't escape and can get to work. So, how do these two worlds, B12 and folate, finally connect? Well, it turns out vitamin B12 really only has two main jobs in our cells. In the mitochondria, it helps with one reaction, but the one we really care about happens out in the cytoplasm. B12 is a critical helper, a cofactor, for an enzyme called methionine synthase. And this reaction, this exact point, is where the stories of B12 and folate finally collide. And in that collision leads us to this concept, the folate trap, which is the absolute heart of this entire process. If you can get this, you've got the whole thing. So that enzyme, methionine synthase, absolutely needs vitamin B12 to work. Think of B12 as the key that turns the engine. If B12 is missing, the key is gone and the engine stalls. When that happens, folate gets stuck in one particular chemical form, methyl THF. It just piles up, it can't be converted to THF to continue on in its metabolic cycle. So what happens is a B12 deficiency effectively creates a cellular folate deficiency by trapping all the available folate in this metabolic dead end. So why is having all your folate trapped such a disaster? How does that lead to the final problem? Well, it's because to build DNA, you need 4 building blocks, right? A, G, C, and T. And that T, thymine, or DTMP, is the problem. The only way your body can make DTMP is by converting a different molecule, D1P, and that conversion absolutely requires a derivative of folate. So with all the folate stuck in the trap, this reaction can't happen. No folate derivative means no DTMP. No DTMP means no DNA. This is the ultimate bottleneck that causes the entire megaloblastic process to begin. And as a quick aside, it's worth noting that we can actually create this same problem with drugs. Chemotherapy drugs like Methotrexate, or even some antibiotics like trimethoprim, work by blocking DHF reductase, which is another essential enzyme in this folate cycle. This creates a very similar blockage. A rescue therapy using something called folinic acid works because it's a form of folate that can actually bypass this blockade and give the cell the THF it needs to get going again. Phew, okay, we have just gone through some pretty deep biochemistry. So let's pull way back now and put all of these molecular pieces together into a clear, coherent clinical picture. Let's do a quick flyby of everything we've covered. Morphologically, what do we see? We see those big oval macrocytes and that classic nucleocytoplasmic asynchrony. For vitamin B12, what do we need to remember? Its complex absorption, which requires intrinsic factor, and its special delivery truck, Transcobalamin 2. For folate, its absorption in the jejunum, and its absolutely critical role in making DMTMP for DNA. And finally, the interaction, the big one. Methionine synthesis is the enzyme that links the two. And when B12 is missing, it creates the folate trap, which leads directly to arrested DNA synthesis. So this brings us to the most crucial point of all. We've gone all the way from the deep mechanism to the absolute importance of diagnosis. And here's why. While both a B12 and a folate deficiency end up looking exactly the same in a blood sample, their root causes and their long-term consequences are completely different. You can't just treat the anemia you see. You have to trace that defect all the way back to the specific break in the metabolic chain to provide the right treatment and the right cure.